meeting of the El Paso County Board of Health to order. And first thing we'll do is we'll call roll. But first I'll say good morning to everyone. Hope you're having a good day. And then we'll call roll. I'm here. Doris Ralston.
Here.
Commissioner Applegate.
Here.
Hunter.
Here.
Dr. Deborah Chan. I believe she's
Here.
online. Thank you, Dr. Chan. Commissioner Geithner. I believe she's
Here.
online too. Okay. Good morning, Carrie. Mayor Havner.
I'm here.
And Dr. Vu. I don't believe he is here yet, but I spoke to him yesterday, and I expect he will be here in a few minutes. And with that, we'll go to item number 2, which is approval of the agenda. And for that, if I could have a motion for approval in a second.
So moved.
Okay, and moved.
Second.
Okay, moved by Vice Chair Doris Ralston, seconded by Mayor Glant Havner. Yeah, and with that, all those in favor of approving the agenda, please say aye.
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 Any opposed? And so that passes unanimously. And we'll go to item number 3, which is Board of Health member comments. And so we'll just go around. We'll start online. And Dr. Chan, do you have any comments this morning?
No, I don't.
Okay, thank you. And Commissioner Geithner, do you have any comments?
I do not, thank you.
All right, and then here in the room, Mayor Havner, do you have any comments this morning? Hunter, do you have any?
I just want to thank Deanne for our chat. I think since your appointment as interim director, you met with everyone individually, and I think that just speaks a lot, and really enjoyed getting to know you a little bit more and talking just a little bit about the board and what we're going to try to accomplish together. So thank you for that.
Okay, and thank you for those comments. Hunter, Commissioner Applegate, Corey.
Just kind of reflect what Hunter said. Thank you for meeting with me, Deanne, for, one-on-one. It was good. So we got to talk the other day and, just look forward to working with you. So hope everything's well. Let me know what you need. Yep.
And thank you, Commissioner Applegate and Vice Chair Ralston.
No comment.
Okay. And I just can't recall, over here, am I a president or am I a chair? President? Okay, so, and this is a vice president or a president pro tem?
Vice.
Vice president, okay. My apologies there, Doris. Okay. And this morning, I won't have any comments this morning, although, well, I will have a short comment. And as I think everybody knows, the city council elections were on April 1st. And so you're stuck with me for at least a while longer. Could have been a very short duration as president of the Board of Health, but that worked out. So I look forward to working with everyone here. And with that, we will then move on to approval of the minutes, which is item number 4. So has everyone had time to review the minutes? Are there any corrections to those? And if I don't hear any comments, I'll assume that means people are satisfied with the minutes. Could I have a motion and a second to approve those?
Motion to approve the minutes from the March, what was that, 26th meeting?
Okay, thank you.
Second.
And so we have a motion from Commissioner Applegate and a second from Mayor Havner to approve the minutes of our previous meeting. All those in favor, please say aye.
Aye.
Okay, any opposed? And so that also passes unanimously. And we'll now move to item number 5, which is public comment for items not on the agenda. And who is it that keeps track of that for us?
There are no comments that we're aware of.
Okay, so we don't believe there's anyone with any comments. If there's anyone in the room, please raise your hand or come up to the microphone. And is there anyone online that we know of? Okay. Okay, so it looks like there's no public comment today. And then we'll move on to item number 6, which is the Finance and Budget Report. And I believe Lauren Meermont will present that for us.
Hi, yes,
Good
I'm
morning.
Lauren Miramont. I'm the budget manager for public health as of February 10th. I've been working closely with Taylor Hartshorn, and I just want to thank him for his support through this transition. It's been really incremental in getting me up to speed, and looking forward to presenting at my first meeting here. Do I need to do this to get it on the, oh, thank you. We're looking at March 2025 financial summary. I just wanted to start the conversation by talking about the first column, the budget column, and just discuss that this is informed by 3-year historical trends. So it is pulling in information from our current year budget, but also informed by trends analysis based on where we have been at this same point in time in prior years. So that is informative, but the actuals column is really where we are at to date for our revenue and expenditures, and so just wanted to highlight that distinction. We use this trends analysis to inform, where we're at with our revenue and expenditures for the year. But, there have been some variances in prior years related to our funding landscape, and so we're looking to just kind of smooth out that trend analysis. Just want to point that out in relation to the program-specific grants variance. So it looks like we're coming in higher than expected for our grants revenue for 2025 based on prior year trends. But if we look at that number in relation to our current year budget, we actually are right on target for our expectations. Then moving down into our license fees and permits, we are actually seeing an increase in that area, and that's due to a variety of factors, including increases in our fees across environmental health, vital statistics, and lab services. Our Medicaid fees and insurance is coming in on target as well. So nothing to discuss there. Our interest income is projected to be lower than budgeted for the year just based on the current environment, but we don't really have any control over that revenue stream. And then contributions, donations, and miscellaneous is also on target for 2025. I guess I'll just pause for any questions or comments regarding revenue before I move on to expenditures.
And, okay, are there any questions? I don't see any hands up online. If you do have a question, just jump in, and I don't see anyone here in the room with questions.
Okay.
So Lauren, why don't you go ahead and continue?
Moving into expenditures, our personnel is trending a little high for this time of the year, but we continue to monitor our personnel expenses. And same thing for our operating expenditures. Those are trending a little high for this point in time, but that is based on some front-loaded expenses that we pay at the beginning of the year, and that should smooth out throughout 2025. I guess I just wanted to take a minute to address our landscape regarding federal grants. I believe it was communicated to the board that we had received a stop work order for some specific grants that we have subsequently received direction that there's a restraining order related to that, so we've been allowed to proceed with that work. So we're just monitoring that situation, but continuing to work as planned. And then I just wanted to thank our finance and accounting staff related to that, because we worked closely with them to kind of stop and then start activity and prepare invoices. And just wanted to thank those staff for their work and supporting us as we adjust to that. So that's my presentation.
Okay. Hang on just one second, Lauren. Great job, but let's see if there are any questions online. I'll look over there. Just for those online, I have to squint, so I don't see any hands up. So I think you're happy online. Here in the room, I do see one of our commissioners, Corey Applegate, does have a question.
Can we go over the why we're in the red on the personnel expenditures, just in the reason of transparency?
Yeah.
Well, and to follow up on kind of what Corey's saying, because I know we all looked at this and kind of had a discussion yesterday, but why did we take it out of budgetary concerns instead of taking it out of fund balance? Since we're so much higher on personnel, just why didn't it come out of fund balance to kind of go on with what you said?
So I think we could have the opportunity to bring forward a proposal to put that into fund reserve. We are likely to need to do some budget amendments as we move through our state contract year, so we may have the opportunity as we progress through the year to make adjustments and bring those forward to the board to utilize fund reserve for one-time expenses.
But you feel comfortable at this point with where you are budgetary?
Yes, at this point, I feel comfortable acknowledging that the funding landscape for public health is somewhat unpredictable at this stage. I think we will get much more insight into our budget once the state fiscal year and many of our state contracts come into play in June. And we bring those contracts forward, and I would anticipate we will need to do some budget amendments at that time and bring forward some of that information again for the board's insight and approval.
Does that answer your question as well?
Pretty much. I just want to make sure that we're good and that, nothing, there's no huge discrepancy in the books. That's the big thing. I just wanted to highlight that, so that way the public knows.
Yes, thank you. And
Yeah.
To what Lauren had discussed earlier in terms of our support from county budget, working together with our partners in the county budget finance team, we are going to be monitoring the budget very closely this year, especially with changes in funding streams and making adjustments as needed. And this is not dissimilar from what we've been through with COVID, with a lot of rapid changes in our funding environment. And I think over the years, we have become very adept at adjusting to those. And I just echo Lauren's sentiments about appreciation for the team in their continuous support and evaluation. And we stay in close contact, both locally in the agency with Lauren for our budget, as well as with county oversight and support as well.
Okay, thanks, Deanne. And I don't see any other questions. So with that, great job, Lauren. We look forward to doing this every month.
Thank you.
I'm sure you do too.
Chairman Donaldson, I actually have my hand up. I'm sure you probably couldn't see it.
I'm sorry. My little eyeballs cannot see on our monitors, the little hands. I see it now, though. Okay, go ahead, Commissioner Geithner.
Yeah, I actually just wanted to add a little bit of context to some of the things that were brought up regarding the state, the federal government pulling back funds and then the restraining order. I have been somewhat involved in those conversations, obviously, with our involvement at the county. And I just feel like it would be beneficial for this board to know, so those federal dollars that are being pulled back, that is an attempt to reduce federal grant spending on essentially things that the federal government does not believe are currently appropriate. So I'm going to give a little bit of my personal take here is that I do not support what our state is doing. They are suing the Trump administration over this. So that's what that restraining order is. So I do not support that. I think that it is a frivolous attempt to try to undermine the will of the voters of the United States. So very concerned about how our state proceeds. I will also say I think that here locally we do a better job of expending dollars than the state does, and that's going to be detrimental to us. Jill Hunsinger-Ryan has been very clear that she wants more of these dollars to expand other things that public health is doing, but they were supposed to always be related to COVID. And so we may have differences of opinion on how we feel about that, but I think that context is important for everyone to understand that the reason that they're being pulled back is because the federal government is saying COVID is over. We need to not be continuing to expend these dollars. And again, I'll say I do think that we do a better job locally than our state. But as we all know, our state is not endeared itself to the federal government and quite frankly doesn't align with the values of our local community as well. So it's a difficult position to be in. And I just wanted to add some context to that restraining order because it's tough. I know no one wants to see their revenue go away. But at the same point, I don't support our state wasting money to continually sue the Trump administration. You've probably seen in the state budget, which is a disaster, that they are looking to pull out millions of dollars to continue to sue the federal government.
For that context, Commissioner Geithner. And if I don't believe there are any other questions or comments, so with that, we will move on to item number 7, which is the director's report. And luckily, we have the director right here, so I'll hand that off to Deanne.
Thank you. And thank you, Board. Appreciate you all being here with us this morning, and Dr. Chan and Commissioner Geithner remotely. Before we go into the presentation that we have for today, I just wanted to provide a few updates related to items that may impact us locally at El Paso County Public Health. In late 2023, this board reviewed all of our environmental fees that are set at the local level, and with support of the Board of Health, we did revise our environmental health fees that are under local control in late 2023, and those went into effect in 24. One item that we were not able to address locally is retail food, and retail food activities make up a substantial portion of the work that we do in environmental health, and we did not adjust those because they are set at the state level. And I just wanted to provide an update related to where we are with that process, because it does have significant impact on the revenues that we bring in within environmental health. So currently, the state is going through the process known as the triennial review to update those fees in partnership with the retail food industry as well. And on April 15th, Colorado Senate Bill 285, updating food establishment inspection fees, moved out of the Senate Finance Committee with unanimous support. And part of what I want to bring forward to the board today is that support in the Finance Committee was not just local public health or state public health, but also we were joined by the president and CEO of the Colorado Restaurant Association, who spoke in strong support for the triennial review and moving forward with the fee increases at the state level. And specifically, Ms. Sonia Riggs, who is the president and CEO of the Restaurant Association, noted the progress that has been made in the last 10 years on this effort, where the model for retail food inspections has shifted to a risk-based approach, where we are devoting the most attention and effort on the areas where there's the highest risk of foodborne illness, as well as an emphasis on education, and that this has substantially improved the working relationship between industry and our retail food program, as well as focusing efforts where there is the highest impact. So if that bill, which is now going to appropriations, moves forward as anticipated, increased fees will be graduated over 3 years, and at the end of that 3-year period, we anticipate anticipate that we will be moving from what is currently about a 40% cost recovery estimated by the state to a 75 to 80% cost recovery for our retail food program, which is very welcome news for our team. The last time fees were increased in this domain was 2015, so this will be a significant impact for our environmental health team. And I would just like to thank our environmental health team who every day is in the field doing these inspections with industry and building the relationships so that we can have support from industry to advance work in this domain. So I think that's good news for us in El Paso County. And I also wanted to make the board aware in follow-up to conversations that we have had related to placing priority on chronic disease. Colorado Department of Public Health and Environment is conducting a listening series related to their work on creating a chronic disease framework that is an indication that they are mobilizing to be prepared to address funding streams and opportunities to address chronic disease with an emphasis on physical activity, nutrition, cardiovascular health, cancer, and pulmonary. So we are participating. Members of our executive team will be participating in that listening session, and we continue work to be poised to take advantage of opportunities to address chronic disease should those funding streams become available through CDPHE. And then our presentation for this month is focused on our child fatality review team. This is an activity that we are required to take on as a local public health agency to convene a child fatality review team. And I would invite Brittany Riffle, our public health planner, along with Emma Bernick to join us to provide some context around this effort that we do locally here.
Thank you so much for that introduction. Bernick, and I am the Public Health Planner for Injury and Violence Prevention. I just want to thank you all so much for your time today so that I can discuss this difficult but very important part of my work. So today I'll be sharing about the child fatality prevention system and the outcomes that this work has for our community. So I just wanted to start by giving a couple of objectives for today's presentation. Primarily, we want to give you a good overview of what the child fatality prevention system is and how the impacts of our child fatality review team influence state and national prevention strategies, and how our child fatality review team has led to the establishment of our youth suicide prevention efforts and injury and violence prevention initiatives here at our agency. So,
Emma,
yeah.
if I could interrupt you for 1 minute, I think a question might actually have to do with what Deanne just spoke about. And I see there's a question online, I believe, with Dr. Chan.
Yes, thank you, President Donaldson. I have, I think, two questions. One was because I didn't quite hear what she was saying about the potential increase in retail food inspection fees. How much are the current fees covering of cost, and what will it increase to if this legislative action happens?
So currently the estimate for cost recovery for retail food is a 40% cost recovery. That is an estimate at the state level. We are working on better defining that at the local level. However, with all of the fee categories that contribute to that, it is somewhat challenging within our financial system to have a very clean estimate because many of our team members who work in retail food cross into other areas as well. So the time and activity that is dedicated to retail food is something that we are looking at to get better local estimates. But we did contribute data to that state estimate. So The plan is that this will be increased 25% in the first year, 20% in the subsequent year, and I believe it's also 20% in the third year, with the goal that that it would bring us closer to an 80% cost recovery. Because our environmental fees, we are just in the process of cleaning some of that and creating dedicated fee categories that can better track the revenue at the program level versus at the totality of the environmental health division. There is still work for us to do to have a solid estimate on what that revenue impact for us will be in the long term.
Okay, thank you. It sounds like it's a potential for quite a bit of an improvement. The second part of my question relates to the fees that we increased last year. During that discussion, what I recall is that one of the reasons for increasing those fees was not only for cost recovery, but also to decrease the waiting time or the response time so that there were fewer delays in required inspections. Do you have any information on the improvement of that service?
Yes, I'll ask Kat McGarvey, who serves as our Environmental Health Division Director, to share insights regarding that. Generally, yes, we are seeing improvements, but Kat will have more specifics regarding that.
Okay, thank you.
I'm the Environmental Health Division Director, and I'm happy to speak to our turnaround times. So we have seen substantial improvements in our turnaround times for conducting inspections, being able to process applications, permit applications for OWTS, and as well as property sale applications. So the increase in fees has also allowed us to facilitate an additional FTE for OWTS that was budgeted in our budget for 2025. We have that position actively being filled at this time. As of right now, we've improved our turnaround times to no more than about 2 weeks on average for an OWTS permit, about 5 business days for a property sale application, and that's allowed us to internally do some process improvement as well. Typically, our plan reviews for retail food are being actively engaged in the process. They can call same day for an inspection in most cases in those instances, and we have staff to be able to support that at this time. So the only other outstanding is from the COVID pandemic when we were not actively out in the field. We do have some inspections on the retail food side we're working to actively get caught up on. And with the additional staff that we were able to hire, the staff is in our budget, but we've been able to fill some vacant positions that are now actively in the field conducting those inspections to help us get caught up.
Okay, Kat. Dr. Chan, further questions?
On the OWTS with the 2-week turnaround, is that 2 weeks from the time a permit is requested to the time that it's approved or to the time that an initial review is conducted?
So that 2 weeks time frame is about from when they make payment, it's actively assigned to a specialist, and then 2 weeks from that point, provided there's no need for design revisions. So if that permit application comes in and it's complete, it's consistent with the regulations, we can typically get those out in about 2 weeks.
Okay, thank you very much.
And Dr. Chan, have your questions been answered now?
Yes, thank you.
Okay. And this will be for Deanne, but I'll just have one little follow-on. Deanne, what we're talking about is right now we have 40% recovery, and we may go up to essentially 80% over this 3-year period. What's the dollar amount? Because that's doubling what our revenue is now. Do you know what that is from
I would ask if Lauren Mearmont, if you could help us get an estimate on what that dollar amount, if we got closer to 80%, would be. We may need to follow up with a memo regarding that. Our challenge being that our fees in the system have not been set up in a way that it is easy to pull that.
Okay.
We could create some estimates, but we may need some time.
Okay.
Lauren, would you like time for that, or do you think that's something you could answer?
Time.
Okay, thank you.
Well, you learned a lot in 1 month already. Okay, and with that, Emma, thanks for your
Yeah, no problem.
pause there, and please continue.
All right, thank you so much. So I think we got through our presentation objectives, so we'll go ahead and jump into the rest of our presentation here. So I wanted to start by giving you all an overview of what the Child Fatality Prevention System is and how it works in Colorado. The Child Fatality Prevention System is a statewide, legislatively mandated, multi-agency network that's designed specifically to prevent child deaths. What this looks like in the state of Colorado is that there are 43 local child fatality review teams, 1 state review team facilitated through the Public Health State Department, and 1 state review team facilitated through the State Department of Human Services. This graphic on the right demonstrates some of the community partners that are involved in child fatality review to ensure that it's a truly multidisciplinary process and includes all of the experts that can share their knowledge in relation to the case. Local review teams look at any sort of child death that's related to injury or violence-related causes. So we review all child deaths 0 to 17 years old that are the result of motor vehicle crashes, sudden unexpected infant death, suicide, child maltreatment, homicide, other unintentional injuries, or any deaths that are listed as undetermined by our coroner's office. To give you a little bit of history about how child fatality started in the U.S., child fatality review teams actually initiated in the late 70s. The first one was developed in Los Angeles after that community saw an increase in child maltreatment deaths and wanted to respond to that. After seeing how collecting that data benefited the community, the U.S. Child Abuse Prevention and Treatment Act was updated to require all states to begin reviewing child maltreatment deaths, and that really set the foundation for the U.S. Department of Health and Human Services to establish a National Center for Fatality Review and Prevention. This infrastructure really helped Colorado set the foundation to be able to pass the Child Fatality Prevention Act in 2013, which required every county or district public health agency in the state to establish a local review team. And in response to that legislation, the El Paso County Child Fatality Review Team was co-founded by our agency and our coroner's office in 2014. So, to give you some insight into our responsibilities as a local review team, here are our duties and authorities that are assigned by the Colorado Revised Statute. We're responsible for reviewing the cause and manner of child deaths, evaluating how they could have been prevented, and reporting our findings into a national database, as well as promoting public education to prevent these circumstances from occurring to other children in the future. So this diagram demonstrates how the process of case review works. After the autopsy and investigations related to the death are conducted, our local review team meets to discuss the case and create prevention recommendations based on our findings. These recommendations are compiled along with all of the other local review team recommendations across the state into an annual legislative report, which ultimately influences changes to support the health and safety of children under the age of 18 in Colorado. So, as I mentioned previously, the data we collect as a local review team can have influence at a state level and a national level as well. Here are a couple examples of prevention measures that were taken by national organizations based on child fatality review data. The first was a major recall that was implemented by the U.S. Consumer Product Safety Commission after data collected by child fatality review teams across the U.S. showed that the risk of death from a product called padded crib bumpers outweighed any purported benefits of using the product. Additionally, the International Safe Kids Worldwide organization made major changes to their drowning prevention guidelines after child fatality review data collected from teams across the nation showed the need to really tailor water safety efforts based on the child's age to be most effective. So now that I've given you kind of a picture of what this process looks like at the state and national level, I want to give you a better understanding of the data that's specific to El Paso County. So over the past 5 years, our top 3 leading causes of death have been sudden unexpected infant death, youth suicide, and motor vehicle crashes. The chart on the right shows a breakdown of cases by the age of the child, which helps us really tailor our prevention measures by recognizing the ages that are the highest risk for a fatality to occur. So, going into those top 3 leading causes of death, I just want to give you a better picture of what exactly we collect in terms of risk and protective factors related to the fatality and how we use that information to tailor our prevention efforts. So, our child fatality review team identified that among infant fatalities, unsafe sleep environments are the leading cause of death over the past 5 years. We've reviewed 64 infant deaths over the past 5 years, and 51 of those have been sleep-related fatalities. We've also found that 37% of our sleep-related infant fatalities occur at 2 to 3 months old, which tells us that that's the highest risk age range for a fatality to occur. This chart on the right demonstrates some of the contributing risk factors that we found in these fatality reviews. So 50 of those 51 sleep-related infant deaths have had soft bedding or toys in their sleep environment. 37 of the 51 were not sleeping in a crib or a bassinet, and 27 of the 51 were sleeping with another person. So based on the information that we've been able to collect, our review team has identified a couple of challenges when it comes to addressing infant safe sleep, and then developed some prevention recommendations as well. The main challenges that our review team has identified is that there's a low perception of risk among community members because a lot of people aren't aware of how commonly unsafe sleep deaths happen in our community. And we've also recognized that there's a huge variation in the type of safe sleep education offered by different healthcare providers in our county. Based on those challenges, some recommendations that our review team has come up with to address infant safe sleep is offering additional safe sleep education outside of healthcare appointments and ensuring the education that we offer is both interactive and repetitive. So, based on those prevention recommendations, some outreach ideas that we're looking at exploring are developing a safe sleep station in our vital records office, which is where community members come to pick up birth certificates after their infant is born, because that's a high traffic area for parents and caregivers of newborns. And then we also use this data to share with Children's Hospital Colorado, who has a coalition focused on infant safe sleep, so that we can best inform their efforts as well. Next, we'll talk a little bit about our youth suicide prevention efforts, and I'm going to pass it off to my colleague Brittany, who is our public health planner for youth suicide prevention.
Good morning, Brittany.
Hi, good morning. Thank you. So as I said, my name is Brittany Riffle. I'm the Youth Suicide Prevention Planner here at the agency, and I'm deeply embedded into suicide prevention efforts happening throughout our county. So as Emma identified, the second leading cause of deaths that we review with the Child Fatality Review Team is suicides. And so I just have a few minutes to highlight about 10 years of effort in this space. And so in 2015/2016, if you were here in the community, you probably remember this. Our county experienced a very high death by suicide rate amongst youth that left a lot of people questioning what is going on, what do we need to do, we need to respond as the community. The timing of that coincided when we had our child fatality review data, as well as a great partnership with the coroner's office. And so that began the establishment of the Youth Suicide Prevention Work Group. So this group consists of about 80 community partners since its inception about 10 years ago, and all working on to make data-driven decisions to help prevent youth suicide in our county. And so,
Brittany?
Yeah.
Could I ask you to pause just for
Yes.
1 minute? And there is a question online.
perfect.
And it actually has to do with the sleep.
Oh, perfect. Yep, we can
deaths.
pause.
A question about suicide.
Oh, yeah,
Okay.
we'll have plenty of time for that for sure.
So you're on deck, but
Okay.
we'll call Emma back. And go ahead, Commissioner Guyton.
Thank you. So one of the things that, when I had kids, one of the big topics that was discussed related to sleep was how often infant sleep deaths have some sort of alcohol or drug component to them, meaning especially those sleeping with those children in those situations where parents are under the influence and maybe are, less even responsive than they would normally in a sleep situation. I noticed that there wasn't anything related to that. Do you guys have that sort of data about the impacts of drug and alcohol in those situations?
Yes, absolutely. I'm actually so glad you brought that up because that is another risk factor that we look at related to infant safe sleep deaths. Of the numbers that I was able to pull for 2019 to 2023, only 7 of those 51 had confirmed parent impairment at the time of the infant death. So because that number was so much lower than those other 3 leading causes, we decided to demonstrate those top 3. The difficult part, I will say, is that it's not always easy in investigation to confirm whether the parent was impaired, or sometimes if the parent was impaired, we don't get that follow-up information in the autopsy because that isn't found out until investigations happen later on. So I would say that 7 of 51 is probably a conservative estimate, and it's definitely something that we incorporate into our safe sleep education and that we plan to have educational resources on when we establish our safe sleep education or when we share data with Children's Hospital.
Thanks. That's super helpful. One of the other pieces, and again, these are very hard things to track, but anecdotally over the last couple of years, I've been hearing from NICU nurses how concerned they are about the prevalence of THC in newborns, that they are seeing. And I know that is both alcohol use and drug use during pregnancy is actually a increase to SIDS. So again, I know that's very difficult to track, but outside of even just the use, once the baby is born, do we have any data on that kind of piece of what the maternal, while they're pregnant, is that affecting the SIDS deaths in our community?
Yeah, so that is data that I'd be happy to pull and share with you guys after that to give you some more accurate numbers. We do actually get any sort of Child Protective Services records with our child fatality reviews, so we're able to see if a DHS referral was notified based on a baby's umbilical cord testing positive for THC, which is where most of that data would come from, so I'm happy to pull that for you all. And then additionally, maternal substance use is another cause of death that we see much less frequently than unsafe sleep environments, but that is something that our review team looks at. So if that's of interest to the board, I'm happy to pull some of that information and send it over after the meeting.
I love it just trying to understand where those things come together, and obviously being involved at DHS at the county level, I'm just really interested in how those kind of pieces are forming together and what we might be able to do. So would love that information. Thank you so much. And I appreciate you letting me jump in and get my questions answered before we move forward. Thank you.
Absolutely. Thank you so much for bringing them up. I'll pass that on to Brittany, and then I will work on collecting that information to send over to you all after the meeting.
Okay, thanks, Emma. Thanks, Commissioner Geithner and Mayor Havner.
I'm looking at the chart regarding child fatalities.
Back to Brittany.
By age group.
Yes.
And then I'm looking at the top 3 of sudden infant death syndrome, suicide, motor vehicle crash. Am I reading this correctly, that 37% is motor vehicle crash and 34% is suicide? What is the percentage currently of teenage suicide in El Paso County, and of all El Paso County under 18 deaths? What is the percentage of teenage suicide, and how much can we tell in this group is attributed to social media bullying?
Okay, so the graph that you're referring to, the 37%, is actually 10 to 17-year-olds of age, so it's not specific to suicide or motor vehicle crashes. And then the 34% is the under 1. So that's what those percentages are, is the age group, not the manner of death.
How can I find out what the percentage of overall childhood deaths can be attributed to teenage suicide, and how much is having to do with the increase in social media and bullying and learned behavior with bullying?
Okay, so I will get to you. I can get back to you about that specific percentage. We do track like information about bullying, and this is known. So was there social media usage around suicide? Was there known bullying amongst people? And that is actually not as prevalent in our specific community as in others. So I can pull specific percentages. That is something we're looking at. Those are newer questions, so we're not going to have as much long term.
Is our teenage suicide rate still more prevalent in boys than girls, or more prevalent in girls than boys? I would like to know that also.
Yeah, that is actually true. So I will get to some rate data at the end because it's some good news that I wanted to wrap up with. But to get to your question, if we are looking at 2022 to 2024, so over the last 3 years, I think it was 62% were males, so sex assigned at birth, and the rest were females. Because public math, I'm not going to do that. 100 minus 61 is 39. Yeah, so 61% males, 39% females.
31.
Yep.
And Mayor Havner, are you, your question answered there?
I think so, but
Okay.
Any of that data you can find out,
Okay.
any of the data you have about especially social media bullying and suicide and basically how that's increasing in El Paso County due to social media use, I would be interested in.
Great.
Okay.
I will see what I can pull. I'm not sure how much we can say increases, but we will definitely look at that and see the connection between social media usage and that.
Okay, Brittany, I think we have one more question
Okay.
for you before
I even get to present all my information.
Exactly. And then after that, I would ask it for the board, let's let Brittany kind of get through her presentation if we could, and then we'll ask
Yeah,
all the
I might
questions
answer
at
your
the end.
questions.
Are you good to the end, Hunter?
Are you sure, Hunter? Okay,
Okay,
great.
okay.
I do have a slide I'll show about some data, and I have a full presentation that I can send you with lots of other stuff. So, okay.
Great.
So getting back to some of the historical work that we've been doing in this space. So like I said, El Paso County Public Health has been involved in youth suicide prevention work for about 10 years now. We make all of our decisions based on data, based on trends, based on what we're seeing, so that we as the community can support youth mental health and also our parents and caregivers. And you're going to hear me say parents and caregivers a lot because we know that their impact, that they're so important to this conversation. So historically, a few things I want to highlight are on the screen if you're following along on your slides. So we have collaborated with El Paso County Sheriff's Office to secure funding for the countywide co-responder unit, which has been an amazing asset to our community. We promoted a man therapy campaign, which targets working-age men to address some of the impact adult suicides have on youth and community culture, as well as encouraging their own mental health and wellness. And then a lot of what we've done is partnered with school districts and strengthened school and community responses following a suicide crisis. So we know, as you look at suicide prevention strategies, some of the best ways to prevent future suicides is how we care for people after they've lost someone to suicide. And so we've done that work. I'm going to move forward and share a few other great outcomes and work that, again, these have all been done through collaboration. So my position is 1 FTE. It was actually supported by the Board of County Commissioners for some critical needs funding a few years ago, which has been super helpful. But otherwise, we do this through partnerships with people in the community. So some other stuff that we've done is we have developed a resource guide. So really just kind of pulling together all of the great stuff that we have in our community into one centralized spot so that people have access to support when needed. We've developed a parent and caregiver conversation guide. And so this was written by parents for local parents so that they have this information that they can talk to their young people about this scary conversation. Because we know mental health, talking about suicide, like I talk about it easy, but this is my job. For most people, it's very difficult and challenging and scary when it's your loved one. And so we want to try to make this as easy as possible. Another great outcome I'll share is that in the last 4 years, again, public math, so since 2021, over 9,500 El Paso County residents have been trained in suicide prevention training. And so we as the Youth Suicide Prevention Work Group are going and training parents, teachers, faith community leaders, people that intersect with young people with these critical tools so that they know how to respond if there is a crisis what to recognize if their young person is not doing well and how to connect them to support. And I will say that I know firsthand that young people are alive in our community because someone attended a training and knew what to do when a young person was in crisis. Another initiative I want to highlight is our Weekends of Hope, and this was started September of last year. And what we recognized was there were 4 awareness events happening in our community for the month of September all around suicide prevention that connected people to the outdoors, raised awareness about what was going on, and so we created a centralized marketing plan so that we could help everyone know what was happening in their area to raise awareness. And then I also did some fun math, which I tracked steps based on, because these are all 5K races or walks, and so we documented how many steps, literal steps, people are taking to support suicide prevention, and we had over 5 million steps with about 1,000 people in our community taking these steps. And so this initiative is just a great way to highlight collaboration in our community and create buy-in across our residents. And then the last one I want to highlight, I'm really excited about because it's new and ties back into what I said about the importance of parents and caregivers, and that's our Mental Health Moments Toolkit. And so through this youth suicide prevention work group, what we looked at was like, where are our biggest supports for young people? And that's parents and caregivers. How do we continue to support them? And how do we reach them where they are? Because if you're a parent, you probably are so busy. There's sporting events and school events and all the things, and plus your job and all the stuff. So we want to go to you. Where are you already gathering? And so we've developed, and when I say we, I'm always referring to my like 50 community partners that are behind me. We developed this toolkit, which are simple statements and facts about mental health that connect to local resources that can be peppered into different events on social media, newsletters, all of this stuff. And so we're really excited to have this as a way to reach parents where they are and support them as they are raising the wonderful future of our community. Okay, and then I have one more data slide, so I'm going to jump to some good news around data, and I'm going to read this so that I say it correctly. So what you're looking at on this slide is a 3-year rolling average for suicide rate amongst youth 10 to 18 years of age. Okay, rolling averages are used to smooth trends for suicide rates when there are small numbers at the county level. Small changes in suicide counts can cause large jumps in rates over year to year, but by using this 3-year rolling average, we get a clearer picture of the youth suicide rates in our county. You can see on the left, in 2015 to 2017, we had an 18.5 deaths by suicide per 100,000 youth in our community. And that was when El Paso County Public Health got involved with our child fatality data and started doing the work. Now, you can see in our 2022 to 2024, noting that 2024 is still provisional, that we have decreased that to 10.9 youth per 100,000 youth. So to me, this graph just speaks of the impact that long-term prevention efforts can have in our community. I've been doing this work for 8 years through a variety of entities. This is complex work. It's hard. It's challenging. But finally seeing some data to verify what we know is working has been super helpful. And so I just wanted to share with you that good news that in our community, we are actually making a dent in preventing youth suicides. And so that's a great win, I think, for our community and for the work of public health. Okay, so that was my information. Now, what questions do you have? And then I'll pass it over to Emma.
Okay. If I could, I know that Dr. Chan, well, actually Hunter was first, then we'll go Dr. Chan, and then we'll go to the vice president, if we can do it that way.
Absolutely.
So Hunter.
Great. Brittany, Emma, thank you. This is really good stuff. Really appreciate it. 2 data questions. One on this slide.
Okay.
Can you go back another 10 years and provide that to the group? I know you don't have it here.
Possibly.
But it would be great.
Yes.
To get at the social media question, I would love to see what the changes were around the 2010-ish timeframe, and you can't see that here.
No.
Because of social media.
Yes, and the screen-based childhood, if you will, of younger.
These kids have never not had social media at this
Right.
point, the kids right now. And then the other thing with this data, to tie into what Hunter's saying, that I would be interested in, and I don't know if there's a way to see that, but with 10.9% there is, does teenage suicide tend to be more prevalent, which I think it is, in higher socioeconomic areas than the lower? Is it tend to be teenagers who have a lot, who expect a lot, as opposed to the lower socioeconomic areas?
Trying to think how to frame this. So we don't track specifically that. I do look at school districts, which I know also there's diversity within school districts as well. And so we can look at some of the school districts. I know historically 11, 20 and 20 have the highest, 38 also as well. But it has touched every single one of our school districts in our county. And we've seen differences each year depending upon.
I'd be interested in D38 specifically, just for what I'm looking at.
Yeah, absolutely, because I know you're up in that area, and so we can look at that and then be really mindful of the, when we get to low counts, it makes it difficult to get a lot of public data, but we'll definitely look at that.
You could also look at it by zip code and look at income. My other question was just a broader data question. I had similar questions to the previous two ones we had. If you go back to page 16, what would be really helpful for me, and this is a takeaway, when you can, if we could get a total for all of the leading cause, or all of the causes of death that you have on page 11. So what's showing here are the top three, right? So the bullets on 11, and then for each of those, what is the, I guess, stacked bar chart, or the clustered bar chart by age group? I think that would help answer a lot of the questions, just at a basic level of what are the age group, like which of these are specific to different types of people? Age is one of them. So that would be one. And if you could go back at least 10 years or so at least, that's number one. And then two, if you're able, based on that, to tell us what has changed over time. So you can see
Changed as
what's
far
spiking.
as-
Is suicide, I'm just throwing things out there, suicide spiking among 15 to 17-year-olds.
Right.
It would help me, and I think help everyone understand what is the data telling us on where to focus.
And I think, I mean, I understand that we're asking for a lot, I do, but I think our number one responsibility in setting an example to our teenagers and setting an example as parents is to set an example on social media primarily, and to set an example into the world to not emulate the kind of behavior that would trigger teenage suicide. That's why I'm very interested in it. You know, I think that we have a responsibility to set a better example, especially amongst social media use, when you're talking about kids in this data section now that have never grown up without a telephone and have never grown up without social media.
Yeah.
I think the numbers are different because of those two factors.
Yeah, and I will say, like, specifically for suicide, it's a very complex issue. And so
I
we
agree.
cannot
One last
pinpoint
comment.
specifically to social media, but I do think that's an interesting thing that we can look more at. And I don't know if we can get fully to 10 years, but we will get as far back as we
So-
can, just given
Yeah.
the data parameters that we have.
That's all I was going to end with. Let's just see what you have, and then we can go from there. Because you already have a lot.
Yeah.
So you have, but it's kind of, you've kind of picked a couple things. I want to see what we have for all of them.
Yeah, absolutely. And things
Okay.
will, change. Like, our database has morphed over the years. So the data we have from, 10 years ago will look different. So we'll just have
Yeah.
to look at what we can pull
But even that
consistently.
view for a 1-year view would be super helpful. But let's just see what we have, and we can review it next time, or whenever, how much time you need.
I would even be willing to come in and review it to not take time away from everybody else, if you
Sure.
will, as well.
Okay. Great. I know this is such an important need, and thank you for caring, because we're talking about the young people in our community who are the future. So, yeah.
Okay, yeah, thank you for those questions. And Deanne, you can we'll talk about whether to have it as part of the presentation or not. And Dr. Chan.
Yes, thank you. I'd like to pull back and get a broader perspective because I I know you might have covered this, but I didn't quite hear it. And that is the general perspective of what proportion of childhood fatalities is overall mortality, and how do you delineate what is considered childhood fatality from childhood mortality?
So for the specific child fatality review team, we are looking at preventable child deaths that are assigned to us through the child fatality prevention system. So it is a smaller subset and part of, like, we're not looking at people who die or children who die from a heart condition in the hospital. That's not what this review team is about. It's about more of these which I know gets into the chronic disease and all of that. But what we're really looking at based on legislation is these suicide, accidents, motor vehicle crashes, and homicides.
And Brittany, I think Dr. Albanese would like to make a comment on this.
Thanks. Good morning. I'm Bernadette Albanese, co-medical director. This graph is not the graph of all deaths in children. Okay, so as it was just clarified, this is just out of the deaths that are assigned to a Paso County Public Health for Child Review, how they break out. So they're biased to injury, right? They're not going to include birth defects and so forth. So the big picture, if that's what you're asking, because I work with the EPI team on this each year. So if you want all causes of death for children, we can do that, and then we can sort of put suicide and injury and suicide are high on the list. I'll just tell you that right now. But anyhow, if you want the perspective of where it fits, say in the top 10 causes of death, which for children is more than enough because they just haven't had enough of life going on to have, die from chronic heart disease and things like that we see in adults. So we can put this in two perspectives. One is what's the totality of pediatric mortality in El Paso County and in the state, because they do. Thankfully, there's not that many pediatric deaths, and so they do mimic one another. And then out of that subset, we can try to pull out the information that you're looking at. There was some comments around sleep-related deaths, and then suicide and some of the extenuating circumstances. And we get that data from two places. One is from the death certificate and the coroner's investigations, and then the other is the extra review that the child fatality team does. So there's other sort of societal and social circumstances, that information gets brought to the child fatality team for the deaths that they review. So it's little bits and pieces of information, but we'll try our best to hone it in. Small numbers in zip codes and so forth will probably make this difficult to do. But again, there's still information there and lessons to be learned. And so just to realize that there's a couple of different ways to package this for you for the questions that you're asking.
How are assignments, who determines what kind of case comes before the child fatality review team?
So that's in the state legislation, which one it is. So when and Emma can correct me if I'm wrong because it's been a minute, but so when a young person dies, their autopsy gets conducted, the coroner's office assigns the manner of death. Based on that manner of death, it gets sent to our state child fatality prevention system, and then they assign it out based on county zip code and representation. And so this is what we're assigned based on their requirements from state legislation.
And so in terms of preventable childhood deaths, let me just give you a couple of examples that I'm interested in. For example, if a child has a chronic disease of difficult to treat asthma, for example, and they are in an environment where their caregivers are exposing them to a significant amount of secondhand smoke, exacerbating their asthma, and then they have an asthma attack and succumb to that. Is that something that comes up for review? Another situation might be vaccine preventable disease like measles, where the death rate for an unvaccinated, healthy individual in the United States may be as high as 0.25 or 0.5%. In developing countries, it can be as high as 1.5%. Those are preventable, and it may have been a failure of the public health system or the caregiver to make sure that individual is adequately vaccinated. Is that something that would come up for review?
So those are not deaths that we would review because we primarily look at causes of death related to injury and violence prevention. Something that we do track is secondhand smoke exposure as well as vaccination status for any child that dies. So that information specific to injury and violence related deaths, we would be able to probably pull for you all. But in terms of those types of preventable deaths that are related to chronic disease, that is not the focus of child fatality review. It's specifically focused on unintentional injury and violence related deaths.
And
Got it.
Lori's got
Okay,
a
thank you. Thank you.
Yeah, Lori.
Thank you, Lori Sego from the County Attorney's Office. Sorry, is my mic on? I think so. Okay. So I've pulled up the statute that assigns authority to the local review team, and the list of causes in the statute are undetermined causes, unintentional injury, violence, motor vehicle incidents, child abuse or neglect as defined in state law, sudden unexpected infant death, or suicide.
Okay, thank you, Lori, for spelling that out. Dr. Chan, further questions?
No, thank you very much.
Okay, well, thank you.
I just have a comment.
And now finally to Vice President Doris Ralston.
I think it's impressive that we've had a lot of preventive education in our community to help prevent. This data looks really good. But we all know from a few years ago we were addressing this topic that a lot of completed suicides. There was our children's hospital, and they have a day program for kids so they can go to school and they can be dropped off in the morning and then school, and then they're picked up in the afternoon so that they can come with the family for dinner and stuff. That there's a lot of uncompleted suicide. I know I had Dr. Albanese talk about that. So while this picture looks really good, what you're not seeing is the attempts that aren't successful.
I'd be interested in the attempts too.
Yeah, that's definitely a whole other conversation, and I've got a ton of information about that. But for the purposes of today, we were trying to really center it on suicide as well. I will say we have been consistent with suicide attempts in our community as tracked by, I'm not even going to name it, but essentially hospital data. And then we all, so we do see that, and that's usually related to poisonings and intentional overdoses.
Thank you for that observation. Doris and Dr. Vu, I believe, has a question also.
Thank you. Thank you for the presentation and the information. I only have 3 questions. The youth suicide graph for Colorado Springs versus Colorado. Can you remind me the rate of suicide in youths in Colorado Springs versus Denver, please?
So I don't have that handy. I can pull that for you. Sure. Yeah, we just usually compare more to the state overall, especially because Denver makes up multiple counties. Yeah. So, but we can pull that.
Okay. Do you remember if we're higher or lower than Denver?
Typically, we are higher, but we are lowering that percentage.
Gotcha. In rates. Okay, perfect. Thank you. Second question is, there was a slide that says that for child fatality related to child maltreatment. Is there a difference between maltreatment and child abuse? In my mind, if there's maltreatment that results in fatality, in my mind, that's child abuse.
So child maltreatment typically refers to like the umbrella definition of both abuse and neglect. Abuse is more specifically defined, especially by our Department of Human Services, whereas neglect also kind of falls under that maltreatment umbrella. So I would say maltreatment kind of covers both, and then abuse is essentially the more severe form of maltreatment, and then neglect is another form of maltreatment that exists among children.
Thank you. So therefore, when we say child fertility related to child maltreatment, can we just say child abuse, just so that we don't have a misunderstanding?
The reason we use the term maltreatment is because sometimes child neglect impacts child fatalities. And so we have had cases, while I will say it's rare, where a child death is related to child neglect. So it wasn't specifically like physical, emotional, or verbal abuse, but there was some form of neglect by the parent or caregiver that led to the child fatality.
So are we making the arguments that child neglect that leads to fatality is not abuse?
That's not, I guess I wouldn't say that's necessarily what our team is focused on determining. The definitions would fall more under what, if the child was referred to Department of Human Services, they have a difference in abuse and neglect, and I'd be happy to pull those definitions to share with you guys, but that's not necessarily, I would say, our area of expertise.
No problem. I apologize, it's not a question, it's just...
No, you're totally fine, I appreciate it.
Okay, I think if...
The question is... thank you for emphasizing the importance of parents and caregivers. So 2 questions related to that is, are parents in general better than non-parent caregivers? And should we just spell it out?
We use those terms interchangeably just because we want to respect kids who might not be living with their biological parents. And so we think having a trusted adult in a parental capacity is super important. And so the language in a lot of the surveys that are given and in those conversations is using those collectively.
Thank you. So that has crossed my mind, but the counter argument to that then is then we may not emphasize enough the importance of a parent caregiver versus a non-parent caregiver.
Could you reframe that question, or was that just a comment? I'm sorry.
Do you think, and do you know if there's any data that says that parents caregivers are better than non-parent caregivers? Not to disrespect non-parent caregivers.
That I don't know if I can speak to. So I think that is, based on experience of the young person, and, I think I could give my opinion, but that's not what's needed here. So
Thank you. So
yeah.
I just want to, in my mind, just opinion.
Yeah, we just try to make it all encompassing. So if you are providing guardianship, parental, like biological parents and caregivers, like you have impact and are one of the most important people in that young person's life. So we just want to make sure that you have that information.
Yes, thank you. I do agree with that. But in addition to that, just personally, I'd like to emphasize the importance of a direct parent involvement. I think that's also very, very important.
Yeah.
In addition to that, are there data, or do you think 2 parents involvement is better than 1 parent involvement?
Again, you might be getting to my personal opinion, so I don't know if there's data surrounding that specific question.
Okay,
So,
even though there may not be data, may or may not be data, do you have an opinion? Or do we have
I do,
an
but
opinion?
I don't know if I'm going to leave that. We can talk later about that.
No, I do
Trying
have
to remain data informed and not
I
an
do have an
opinion.
opinion because this is public health, right?
Yeah.
I mean, it's just not fatality, but it's everything else.
Yeah.
So I
But-
do have an opinion. I think 2 parent involvement in a child is better than 1 parent. 1 parent involvement in a child is much, much better than no parent involvement.
Yeah.
Thank
Yeah.
you.
And Brittany, so I just want to say, like, for anybody presenting, if it turns into your personal opinion, I respect the questions, but you certainly don't need to
Great.
be forced to give your opinion on that. So just don't.
Thank you.
And I think there is some data, though, Dr. Vu, on certain metrics that are measured with, crime and success and educational attainment on how much parents are involved. I don't think we have that here to discuss today, but I think in general I agree with what you're saying. But also for presenters, don't feel like you have to get up here and bare
I have a
your
lot
soul.
of opinions. You don't want to open up that can of
Yeah.
worms, okay?
Okay. Now, with that, it looks like everybody in the room who had a question has asked their questions. Oh, I do see, I look to the right at the right time. Commissioner Geithner, I believe you have a statement or a question.
A little bit of both, actually. I wanted to say, I know there was some conversation earlier about the data, and Mayor Havenar suggested that maybe Hunter get that information offline so that it didn't come to the entire group. And if the entire group doesn't want it, I think that's fine. I would also love to see that information. And I wanted to kind of make an observation from the questions today. I think what we are continuing to see from this board is a desire to look at the big picture and assess what the real top problems are in our community. We know that the child fatality review is a statutory requirement, but what I keep hearing are questions where people want to zoom out and say, what are the real problems in our community and are we addressing them? And answering that question, in addition to like, yes, we need to perform our statutory function. So I just kind of wanted to point that out as a trend on our board. And I think if everything that we are doing is keeping that in mind, that I think this board will really appreciate, from what I'm hearing, those opportunities. And I really appreciate Dr. Vu's question as well around some of this trend data. We may not have this data internal to public health, but there's a lot of trend data and information about these particular topics that we should be informed. And respectfully, though, I agree, we always want to speak respectfully about positions and people's choices. I feel very strongly about that across the board. At the same point, we can't be so afraid of offending folks that we are unwilling to look at data. That is a reality. So that's more of a little bit more of a statement there. And I wanted to point out that, you know, generally at the county from a DHS perspective, which this is obviously very deeply entwined with, we feel very strongly about two parents. There's a lot of federal data and research about how important it is to have strong families. And we should acknowledge that. We should share that with our community. We should promote it, in my opinion, which is why we have things like the Center on Fathering in El Paso County. So I understand we want to be respectful. I do think that's incredibly important. Having a family where there are lots of different situations, you know, we don't want to shame anyone. We certainly don't want to do anything that you know, is in that realm. But at the same point, I think promoting the data and looking at some of that information that's out there is a very valuable way to actually affect public health. If we know that strong families create less of these risks in our community, then we should promote those things. Thank you.
Okay, thank you, Commissioner Geithner. And I do have one question if everyone else is done. And on the slide on slide 21, I think it is, which just shows, I believe it's El Paso County compared to the state.
Yes, sir.
And we're at 10.9 most recently, and the state's at 7.8. So, and it's clear, and we have been, you know, all the way back to 15, 17, higher, and much higher at that point. Is there a hypothesis or generally accepted reason for that we're higher than the state average? Is it because the state total is counting in rural counties where the suicide is lower, or maybe that has nothing to do with it? Is there a general hypothesis on this, why we're consistently higher? Or do we not know?
I mean, yeah, go ahead and go for it. Okay, I just think some of it is connected to our community demographics and some of the risk factors.
This is children. I mean, I know, like military, I would accept that. Military
families, like that can impact having, you know, that perception. We also see in our community a very high academic performing high school students, and pressure to perform is something that we see consistently in our youth suicides. And so, you know, some of our school districts are wonderfully high performing, which is great, but that also does put some other risk factors. And again, it's like, you know, like I said, a very complex community issue, but I think there's a few things that just set us up to increase risk factors. And just because you have more risk factors doesn't mean that you're going to have a higher suicide rate, but which is why we're trying to instill a lot more protective factors. So those things that can counterbalance that. Also in our community, just feeling that sense of isolation. And so that can be a risk factor. And so we see people not.
Would that, if I don't want to interrupt.
Yeah, no, you're good.
Why would that be higher in El Paso County than throughout the state?
That I don't know, but I hear that all the time. Like, you know, when people move into El Paso County, I've heard anecdotally, again, this is not data driven, but just like, yeah, like everyone's like, there feels like less connection and it's harder to integrate into the community culture. And so that can produce levels of isolation. So
Okay.
those are some of my thoughts. Dr. Albanese, is there anything you'd like to add or?
Yeah, I think, you know, sometimes all your questions are excellent, and the discussion is fabulous today. I think some of the detail that you're asking is not something that's necessarily systematically comparable from one geographic area to another. There is a state surveillance system around suicide that we can look at to see if we can tease out at least, I don't know who was asking about some of the geographic differences in terms of our counties up and down the I-25 corridor, which may have a little more alike than in some of the rural parts of the state. So we can look and see, but the fidelity of the information may not be specific enough to answer your question. So I think for the child fatality team, they, you know, when using the term risk and protective factors are the behaviors and social circumstances around an individual that contribute to either making a decision about self-harm or not making a decision about self-harm, and resiliency to deal with difficult situations. We all have gone through that in our own lives. So I think a lot of the focus ends up driving to that conversation, because at the end of the day, it's what's going on around the individual over time that either builds up and busts or builds up and is dealt with. And so it's just focusing on what those circumstances are, how can they move from things being risk behaviors and risk circumstances to things that are protecting, things that are supportive, things that are build resilience to deal with, you know, what life throws at you as a teenager. So I think that ends up being what a lot of the discussion and the focus is how to build the skills and the environment that are more supportive and helpful, rather than pointing children in a more, you know, to make a decision about injuring themselves. So, and that rolls up not just tiny specific to our county, that rolls up from just learning about child suicide around the state and around the country. So there's enough similarity. I mean, like I said, not getting to the absolute, well, I live in Colorado Springs and it's right there, but there's enough similarity in the themes of what's learned from reviewing youth suicides, particularly in the child fatality, that you just get a sense of what those common themes are.
Okay. Yeah, thank you for that. And
It looks like Dr. Chen had her hand up too, sorry.
And go ahead, Dr. Chan.
Okay, thank you. I wanted to make one comment, and I have one question. The comment relates to the discussion between that was brought up by Dr. Vu in terms of single parent or two-parent households. I do agree that the national data and significant numbers of studies indicate that that there's less risk in stable two-parent homes. However, I do think that it's similar to being born beautiful or being born rich. It's just luck whether you are born into a family like that. And for guardians who are not the parent, it is, in my mind, likely a riskier situation simply because the child may have been assigned to a non-parental guardianship because the environment with the parents was so poor, which unfortunately gives that child a they're behind, and they're traumatized, and so they're more likely to express risky behaviors. And that doesn't necessarily mean that it's the fault of the guardian. It's simply what came before. That is my opinion on it. The question that I have is a little bit different, and that is when we see these trend lines, we saw the trend of youth suicide come down in both the state of Colorado and in Colorado Springs, and then there was a slight rise, and then there's a decrease again. How do you know that these trends are the result of this program rather than some external force outside of this program?
That is why I was really clear to not say this program or this work group or collaboration caused this, but I do think there's connecting points of when there's strategy around prevention, when you have 80 different organizations represented sharing the same information going about this, like I do think that has impact, also in helping reduce the stigma around having these conversations. And so in no way are we saying that the youth suicide prevention work group in El Paso County caused this decline, but just saying that there is data to show an impact of community collaboration. And in order to have collaboration, you need someone to kind of backbone and lead the charge. And so that is what public health's role has been in that. So, because prevention is tricky, and I know Doris has said that a few times, we've talked about that a few times, but yeah, prevention is tricky and challenging. And so, yeah, that's what I'll say.
Thank you.
Yeah.
Okay, thank you, Dr. Chan.
Okay, so we have, oh, I'm sorry, go ahead. There's a couple more slides, so I didn't know if you were, yeah.
Okay.
So we have two more related to motor vehicle crashes, because we did want to identify top 3. If you're ready to move on, we can pause for the day for that.
No, go ahead. Do
Okay.
the final slides, please.
Yes.
I won't take up too much more of your time. I just wanted to highlight our third leading cause of death and some data around that as well. And I wanted to thank you all so much for your wonderful questions and engagement. We weren't sure exactly what the board would be interested in related to this data. So we have obviously many more data points that we can pull, and I look forward to having further discussions about this work because it's very near and dear to my heart. So to wrap up, I just wanted to highlight our motor vehicle fatality data as well. This chart on the left demonstrates the position that the decedent, the child who died, was in at the time of the crash. So as you can see, the majority of our children who die by motor vehicle crash are actually the passenger rather than the driver or a bike pedestrian. However, we do see about a little under a third of our decedents being drivers, and then we see a little under a quarter being not in a vehicle, so that would refer to pedestrians, kids on bikes, or other vulnerable road users. And then this chart on the right demonstrates the type of vehicle that the decedent was in if they were not a pedestrian or a cyclist. So as you can see, the majority of our child fatalities occur in a car, but we also see a decent amount that are contributed to from children who are on motorcycles or using all-terrain vehicles like ATVs. So that's really highlighted an area that we focus on with our community partners who do a lot of youth traffic safety engagement. Do you have a question?
Yeah, Emma, do you know where these fatalities happen? So are these all on I-25? Are these suburban intersections? Are they all the rural parts of the county? Is it a mix?
Yes, I would say it's a good mix. So we can't always share the exact location of the crash for confidentiality reasons, but something that we're looking at doing is some hotspot mapping where we can look at over 10 years of time, are there a concentrated area of crashes? Another resource that I'm happy to share with you all is we have a community partner that actually develops a crash data map where they track all crashes in El Paso County, and you can see the exact area that the crash occurred, what the contributing factor was, the age of the child or person that died, and that's not just for child fatalities, that's for all crashes, but that's definitely information I can pull and bring back to you.
Yeah, that would be great. Because again,
Yes.
it fits into this theme of what is the data telling us to inform what we do? Because if, 80% of these are at 8 o'clock in the morning outside a school stop, or something like that, well, maybe we should do something with that. Just completely hypothetical, but that sounds great.
And
Thank
how
you.
much involves texting?
Yes, I would be happy to pull that. Distraction is another one where it's not always easy to confirm whether or not the child was actually texting at the time that they were driving. And as you can see, a lot of our crashes happen where it's not a young person driving as well. But we do have quite a bit of data on distracted driving, as that is becoming an increasing concern within the traffic safety community. So I'm happy to pull that for you.
Okay, and I believe Dr. Vu has a question.
Yes.
Thank you. This is important to me to discuss this. So based on this graph, my interpretation is that motorcycle and ATV fatality rates are much, much, much higher than car and SUV fatality rates. Can you comment on that for me, please?
Yeah, so these are not the rate, these are just the pure number of fatalities that have occurred where the decedent was in that vehicle. I would be happy to look at the rates for you if you're asking like about the rate by the number of people who own motorcycles versus, you know, the amount of fatalities that we see. These are just the pure numbers, so it's not a rate. But what you said is true in the sense of we do really need to highlight that motorcycles, ATVs, and any other vehicle that's not a car is still a place where young people and people in general need to practice safe driving behavior.
And just one more thing, if you're pulling data, how much child-related vehicle fatalities have increased since the passage of retail marijuana?
Yes, so actually what I'll highlight on this next slide here in some of our motor vehicle safety efforts is that something that we're looking at through our community-based impaired driving prevention grant, which is funding that we receive from Colorado Department of Public Health and Environment. And that funding is really cool because it comes from the Persistent Drunk Driving Cash Fund, which is made up of DUI fines. So the people who are arrested for a DUI have to pay for the prevention efforts that we do through this program. And so within that grant funding, what we've done is a community needs assessment, looking at talking to our traffic safety professionals, our law enforcement, asking them what they're seeing on the roads and what they feel is contributing to this issue. And we've also done something called an impaired driving data walk in partnership with our DMV, where we actually had impaired driving data available for community members to look at and ask for their feedback on what they wanted this funding to be put towards. And lastly, we've done a lot with this funding to partner with law enforcement, where we've been supporting our law enforcement officers who demonstrate excellence in DUI enforcement. And that's really opened the door for us to have a great partnership with our sheriff's office, and they've asked us to come present about impaired driving prevention to their teen law enforcement academy, because they're recognizing that they want future law enforcement officers to be engaged with prevention as well. Additionally, another project that we've been working on related to motor vehicle safety efforts is developing an emergency contact identification system in partnership with our maternal and child health program. So that will actually provide emergency contact information that can be strapped around a seatbelt specifically for children and youth with special health care needs who wouldn't be able to communicate about their disability or their parents' emergency contact info in the event of a crash. And lastly, our efforts are actually being recognized across the city and the state. So El Paso County Public Health has been asked to sit on a transportation and public health leadership team at Colorado Department of Transportation to learn more about how public health and our behavioral change frameworks can influence traffic safety efforts in the future. And we're also sitting on an advisory board with the City of Colorado Springs for their Safe Streets for All grant to give the same advice and guidance. So that's just highlighting a couple things that we're doing related to motor vehicle safety. And I have one more slide for you all, and then I'll take any additional questions that you have. But this last thing that I really wanted to end on is highlighting how often the deaths that we review are preventable. So the very last question that we enter into our database and that we ask our review team at the end of each case is whether they or not they felt that child fatality could have been prevented. And as you can see, the majority of the time we do feel that these deaths are preventable, and there are only 3% of our cases over the past 5 years have we felt were truly not preventable. And as you all can imagine, this work is incredibly challenging to review child fatalities, but I think this information is really what keeps our child fatality review team going, is knowing that the data and the information that we can collect will help us prevent these circumstances from happening to any other child in the future. So that is the last of my slides now. If you have any additional questions, I'm happy to take them.
Okay, thank you, Emma. And let me look. I don't see any online. We've, everybody except for Corey, I'm not sure what's going on over there, has asked lots of questions. You're doing, you and me, man, it's good. Are there any other questions? So if not, I want to thank you, Emma and Brittany, for that presentation. Generated a lot of questions and some requests for further information, and perhaps that'll come back as another presentation, or else individual meetings or an email with the data in it. So we'll sort that out. But thank you very much. Did you have anything, Deanne? No. Okay. Okay. Thank you.
Thank you all so much for your time.
And with that, we'll go to our final item, number 8, which is a new contract. And I believe Daisha Hudson is going to present this. It's a suicide prevention expansion in El Paso County. A resolution to recognize and appreciate contract funds, and we will need to vote on this after the presentation.
Good morning. I first just want to commend Brittany and Emma for their work in this presentation, and thank you all for the engaging conversation. It's incredibly challenging work, and they do an excellent job, and I just wanted to thank them. So thank you. Again, I'm Daisha Hudson. I'm the Community Health Promotion Division Director. I'm here today to present the contract for suicide prevention expansion for El Paso County. You've been provided with some detailed information within your packets, but I'm going to try to provide just a high-level overview of what this looks like. El Paso County Public Health has been awarded $168,605 from the Colorado Springs Health Foundation. The foundation provides one-year funding for one-year projects that align with their mission and funding focus areas. And one of their focus areas happens to be suicide prevention, which aligned with efforts that we already have ongoing in the community, as you've heard about today. Our agency was notified about this funding because of our current efforts were recognized as aligning with their focus area. Our agency also has 2 existing public health planners that already convene partners and facilitate coordination around suicide prevention and behavioral health here in El Paso County. And as you've seen today, the public health planner positions have really demonstrated success in optimizing community partnerships and reducing duplication of efforts. They're really seen as like a hub, and being able to pull in all the partners and reduce the duplication of efforts is so important. And we were recognized as being funded for this project because of that, because of their success in those areas. Approximately 70% of this funding will support 0.5 FTE of each planner, so a total of 1 FTE. These 2 positions, the suicide prevention planner and the behavioral health planner, have historically had little to no operating budget, and so this grant is going to help us leverage and diversify our funding streams and allow us to expand on the current community efforts and also be able to provide some professional development for these staff. So aside from the funding that is to support personnel, the remaining funds are going to be used to support the following key project deliverables, which is mental health first aid instructor training. Our suicide prevention planner is already trained to be a mental health first aid instructor, but we'd like to also train our behavioral health planner. This is going to help us be able to expand our capacity to not only train our internal staff, so our agency is committed to training all new staff in mental health first aid, but also be able to help us expand our capacity to offer these services to other county partners. We've already done that in some capacity, but this is just going to be able to help us expand that. And then, you know, more importantly, I think we want to provide these services to the community, and so providing this training, you saw in the presentation today, I think it was 9,500 people have been trained in mental health first aid. This is going to help us build capacity to train even more people with a focus on parents and supporting our community partners in their suicide prevention efforts. Another aspect of this funding is implementing a comprehensive media campaign to raise awareness for the Pikes Peak Rising 360 platform. This is a free tool for the community to use as a resource to support their mental well-being. And then, you know, we already participate in community outreach, but again, this is just going to be able to help us expand those efforts, allow us to have some materials to share, generate some more engagement with the community. And then lastly, like I mentioned, professional development for our staff with little to no operating budget. It's really important that we provide some ongoing learning and development. They're already highly skilled and have a lot of expertise, but we want to make sure that they're up to date and current on the latest trends and best practices.
Okay, thank you for that presentation, Daisha. And I'm going to look, I don't see any hands up online, and I don't know if there are any questions, but what we'll need is a motion to, and I'd ask Lori, would the motion really be to approve resolution 2025-02? Would that be a good way to phrase it?
Yes.
Okay. and that's in our packets, and it lays out how the funds would be spent. If there are any questions, let's go ahead and take those. If there aren't, I'd ask for that motion to approve Resolution 2025-02.
I'll make a motion to approve.
Okay. Well, we'll go ahead and take a motion in a second, then we'll have discussion, and Carrie's, we'll just put that in as discussion.
To approve Resolution 2025-2.
Okay, so there's a motion by Mayor Havner, and is there a second?
I second.
Okay, and a second by Vice President Doris Ralston. And now we'll have this, so the motion on the floor is to approve this resolution 2025-02. We'll start with Dr. Vu. Go ahead.
Question?
Yeah.
Discussion?
Yeah.
Do we need to approve the contract first?
Well,
That's what we're doing with the resolution.
yeah, I believe it's in the resolution, and I'll ask the attorney.
My
See, I
understanding
know to
is
ask
we
attorneys.
approve the contract first, and then we should approve the resolution, how to spend that money, how to appropriate that money in the contract.
I'm happy to do it that way if that's the correct way, and perhaps that's what Commissioner Geithner was going to point out also. While Lori's looking at that, go ahead, Carrie. What would you like to ask or say? And Commissioner Geithner, if you had a question or a comment, please go ahead.
Thank you. Sorry. Yeah, I'm curious if anyone else on the board or staff has seen the most recent Common Sense Institute release of research on this particular topic. Happened to see this come out. It came out on the 15th of this month, and it is kind of a comparison on mental health across Colorado, including what's going on with the Behavioral Health Administration, some maybe criticism of how that's being rolled out. But I think the relevant piece here is that some of the key findings found that increased rate in suicide in El Paso County, but specifically related to, or I guess the specific demographics that were pointed out were, middle-aged white men, particularly that work in the construction industry. And so I'm curious if you have seen that report, and if there is any thought about how we might use some of that data and information to look at those specific demographics and areas where this is the most prevalent.
So I have not seen the report, so I can't speak to it. Did you have something you wanted to? Go ahead. No, go ahead. Yeah, thank you.
So I have not yet seen that report, but the populations that you mentioned are not surprising to me. So I myself am embedded into other suicide prevention collaborations that are happening across the community that are looking at some of these larger populations at higher risk. And so this funding with my position will help me continue to work and support that. And so yeah, we are monitoring and looking at that, and there's actually a whole strategy and strategic plan happening right now to really look at how do we go deep in some of these other populations, and actually modeling after some of the stuff we've done with youth suicide.
And Commissioner Geithner, any further question or comment?
No, thank you for just letting me know. It seems like you guys are going to be looking into that, and I just recommend anyone who hasn't seen that newly released research from Common Sense Institute might be valuable to see what's out there, because we are specifically named.
Great, thank you so much.
Yeah, thanks for pointing that out. And I'll now just ask Lori. Lori, should we go back and approve the contract before we do the resolution, or does the resolution cover the contract also?
It looks like the resolution only covers the appropriation.
Okay.
So I think that you could either do two separate motions, or you can do a single motion to approve both the contract and the resolution.
Okay, would you like to?
I'll amend my resolution to do that.
Okay, so the
I'll amend my movement, yeah.
and is there a second? I believe it was Doris.
I second.
Okay, so the resolution on the floor would both approve the contract and also approve the resolution 2025-02. Any further discussion on this topic?
I'm assuming the resolution is only appropriation of fund for 2025, and next year we have to have another resolution for appropriation of fund for 2026, correct?
If the grant's received.
The resolution appropriates it for 2025. Since you've already adopted a 2025 budget,
Right.
it'll just be rolled into your 2026 budget for the remainder of the contract.
Thank you. Just want to clarify that.
Yeah, thank you, Dr. Vu. Anything else before we vote? Okay. I don't see any other comments or questions, so all those in favor, please say aye.
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 Any opposed? Okay, so that passes unanimously.
Thank you so much.
Thank you. And with that, we really don't have any other further business, although Dr. Vu got in a little bit late today, so I just give him the opportunity if you had any board member comments you'd like to share, Dr. Vu.
No, thank you.
Any alibis from anyone in the room?
I just wanted to say one thing.
Yes.
Deanne, the listening session on chronic disease, is that open? Could we, if as individual board members, participate?
I would be happy to follow up with that and see what the opportunities are to expand that.
Okay, thank you.
And with that, I'm going to try to find one thing I saw in this, in our packet for this month. I think it's good news. And it was, it's on page 3 of our packet, and it points out that the turnover here at El Paso County Board of Health has fluctuated from 18 to 31% from 2019 to 2022. And it decreased to 23% in 23 and 22% in 24, and is at only 3.6%. So far this year, we've only had 3.6% turnover, which those numbers seemed, I thought, well, geez, some of those numbers are kind of high. But then a little further in that paragraph, it points out the national turnover rate in 22 in public health nationally was 46%. So much less here in El Paso County at El Paso County Board of Health. So I don't mean to open another topic of discussion, but I think that's great news, and that shows, I think that it's a great place to live. I think it's a great place to work, and thank you for everyone that does work here and for what you do. And with that, if there are no further comments, then our meeting is adjourned.